So parents are frequently worried about what happens during an evaluation, so I'd like to share and hopefully alleviate some of the concerns. During the evaluation, we try to make the child and the family as comfortable as we can. In general, the evaluations take place in a playroom or a comfortable setting that doesn't look like a medical office. So there are toys, there are chairs, there are the little chairs that children can sit on, and we allow them to explore the room. If a child is comfortable very quickly, we will in general try to engage them and interact with them. But frequently children in new places are a little bit nervous, so we often let them play and we watch them play. We watch to see what kinds of toys are they choosing, how are they choosing to play. We watch to see whether they look at their parents and whether they try to get their parents to play with them. We watch to see the relationship, if they check in with their parents. And because most children, any child is a little bit nervous in a doctor's office. We look for them to be reassured by their parents. While the child is playing, we will speak with the parents and ask about the child's early history, mother's experience with pregnancy and delivery, any early medical issues, and then we start asking a lot of questions about medical issues. For example, is the child eating a healthy diet? Are they picky eaters? Do they have constipation or other gastrointestinal issues? Have they ever had a seizure? Is a parent worried that they might be having staring spells that could be a seizure? Have they ever had a developmental regression or a loss in any kind of skill? What's their coordination like? Are they able to play with other children? What kinds of things do they like to play with? One of the other things that we ask about frequently is sleep, because sleep is a common problem. Sometimes children have trouble falling asleep. Sometimes children have trouble staying asleep. Sometimes they want to sleep in odd places, like in a closet or under the bed or all over the house. And so we find that it's really important that children sleep in order to learn, and it's really important that parents sleep in order to be able to parent. So we frequently have very long discussions about sleeping. During this visit, we also look at a child's growth parameters. We look to see, are they growing well? What's their weight? What's their height? What's their head circumference? If their head is small or large compared to their body, that is going to make us think about getting further testing, such as imaging of the brain. If the family talks about concern for staring spells, we might get testing that would look for seizures. Sometimes we do laboratory tests looking for inflammation or allergies related to foods. So we really are trying to pull out the most common causes of medical issues that we see in children with autism. After we do that medical interview and try to tease out where the child's strengths and weaknesses are based on their parents' perceptions, we play with the child. And that could be following the child's lead by what we've seen them play with, or maybe the parents have told us what kinds of toys they like, so we will pull those toys out and try to play with them. We can get both an assessment of how they play and also a developmental assessment. What kinds of skills do they have? Are they able to scribble or draw? Do they like to build with blocks? Do they recognize that certain colors are the same, so we see them sort of automatically putting different blocks of the same color together? So we can ask them, do you know what color this is? Or more frequently what we will say is, can you give me the green block? Can you show me where the blue block is? So that they don't have to speak and they can just show us what their skill level is. We might pull out some books to look at pictures and see what interests them. We'll call their name to see how quickly they respond to us. We might ask them to do something like pass a certain toy to see if they can follow an instruction. So we play. And I think sometimes that's a little bit confusing for parents because we're playing. But what we're really doing while we're playing is we are assessing and both the child's developmental skills and their social interaction skills. So a parent can help by helping us make sure that the time that we see the child is good for the family and good for the child. So we want the child rested. We don't want them to be needing a nap. We don't want them hungry. So coming prepared and with the child happy and ready to engage with us is really helpful. If the parent has a particular concern, like there's a certain behavior that's really worrisome or bothersome to the family, and they want to make sure that we see it, if they can bring a video of that, it's really helpful. So the most common age for a child to be diagnosed with autism is somewhere between 18 months and 2 years if there's been a concern. Frequently, children are diagnosed much later because we really haven't identified all of the right symptoms. So we really want to have a diagnosis between 18 months and 2 years. The first signs of autism seem to come much earlier than that. And often, families will tell us that if they have a child who's neurotypical and developing normally as their first child, that when their next child is born and that child has autism, they frequently recognize the differences in behavior and development very early. But if your child with autism is your first child, you are much more likely to have difficulty seeing the early signs, because it is challenging to know what is typical and what is not typical. What are the real concerns for autism?